Hello students, in today's video I'm going to tell you about the Alzheimer's disease. Alzheimer's disease is basically related to your brain. It will affect the part of your memory, the way you memorize the things, the way you recognize the things in a day-to-day life. It will affect that memory part and let you be in a condition of dementia. So progressing to the definition, Alzheimer's disease is slowly progressive disease of the brain which is characterized by the impairment of memory and eventually a disturbance in the reasoning, planning, language and the perception. We can say Alzheimer's disease is a progressive dementia affecting both the cognition and the behavior with no known cause or the cure. So there is no particular cause of the Alzheimer's disease, neither the cure of the Alzheimer's disease. So the patient eventually lost all the cognitive, analytical, and physical functioning, and the disease is ultimately a fatal. So, what are the etiological factors behind the Alzheimer's disease? The several genetic and environmental causes have been explored as potential cause of the Alzheimer's disease, like genetics. They are most aggressive early onset cases are attributed to mutation of an Alzheimer's genes located on the chromosome 14, which produces a protein called presenilin, and second is your environmental and other factors. Environmental factors can be a stroke or alcohol abuse patient or a repetitive or severe head trauma or down syndrome and a lower level of education, in particular traumatic head injury in combination with the APOE4 genotype has been associated with an increased risk of Alzheimer's disease. So these are the etiological causes of Alzheimer's disease. So what are the clinical presentation? What are the clinical perspective the Alzheimer's shows? The before as the Alzheimer's disease start to developing, so it will not it is almost imperceptible without any abrupt changes in the cognition or the function. So it come into the life very slowly. It deficits the occurs progressively over time and affecting multiple areas of the cognition. So for the treatment and the assessment purpose, it is divided into two parts. First of all, your cognitive symptoms, it has to be cured, and next is your cognitive, which is your behavioral symptoms. So cognitive symptoms are present through the illness, whereas the behavioral symptoms are less critical in any of the Alzheimer's disease. So these are the stages as the Alzheimer's progresses. So it is divided into 7 stages and it has been scaled by a global deterioration scale of cognitive. So first is a normal stage where there are no subjective or objective changes in the intellectual functioning. Second stage is the forgetfulness, which we all suffer in a common way, like complaints of losing things, forgetting the names, does not interfere with the job or social functioning, generally a component of the normal aging. And the third stage is the early confusions. Cognitive, whatever your cognitive declines, the causes interference with the work and social functioning. And anomia, as I have already told you, what is anomia? Anomia is a problem with the word finding, impaired recall of the words with no impairment of comprehension or the capacity to repeat the words. Okay, so loss may cause anxiety for the person. So fourth stage is the late confusion or early Alzheimer disease, in which the patient can no longer manage the finances or homemaking activities, and it is very difficult in remembering the recent events, whatever the events has been occurred, and it begins to withdraw from difficult tasks and to give up, the patient give up their hobbies and always deny with a memory problem. So fifth stage is a early dementia, which is also known as moderate Alzheimer disease, where the patient can no longer survive without an assistance and frequently disoriented with regard to time. The patient don't know what is the date, year, or season, and difficult in selecting the clothes, and it cannot recall for the recent event in severely impaired patients. It always forgets some details of the past life, like their schooling, where he attended first school, where he works. Okay, so the functioning may fluctuate from day to day. A patient generally denies the problems, and it become more suspicious or tearful. It loses the ability to drive solely, and as the symptoms progresses, it comes into the stage 6, which is a middle dementia, which is known as moderately severe Alzheimer, where the patient needs assistance for the activities of the daily life, like bathing, dressing, toileting, and the patients experience difficulty interpreting their surroundings and forget the names of the family and the caregivers, and forget most details of the past life, have difficult in counting backward from 10 to 1. The patient started feeling agitation, paranoia. You already know what is paranoia. Paranoia is a thought process believed to be heavily influenced by the anxiety or the fear, basically irritation and the delusions. Okay, so next is your deletions, which are common, and last stage is your stage 7, and it is a late dementia where the patient loses the ability to speak, may only grunt or scream a little bit. He also loses his walk. He not able to feed himself, inconvenient of urine and feces, consciousness reduced to a stupor or in a coma state. Okay, so as you see all these stages, so basically Alzheimer's disease symptoms are divided into three main parts. First is your cognitive part. Cognitive symptoms are memory loss, in which the patient is not able to recall and start losing the items. uh, it is known as aphasia, anomia, apraxia, agnosia, disorientation, impaired executive functions. These are our cognitive symptoms. Non-cognitive, that is your behavioral disturbances. Your patients will be physical and verbal aggressions, motor hyperactivity, uncooperativeness, wandering, repetitive mannerisms and activities, and combativeness. The patient will go into the depression, and the psychotic symptoms start appearing like hallucinations and delusions. Third is your functional abilities, in which the patient is not able to care for herself, like he will not be able to dress herself, bath, take toilet, and eating. So these are the 10 warning signs of the Alzheimer disease, according to the Alzheimer Association has been developed as a warning signs. First is your memory loss, difficulty performing familiar tasks, problems with the language, disorientation to time and place, poor or decreased judgment, problems problems with abstract thinking, misplacing the things, changes in the mind or behavior, changes in personality, and loss of initiative. So, what are the diagnoses? So, the Alzheimer disease is diagnosed when a person has sufficient cognitive decline to meet the criteria for dementia, and the clinical course is consistent with that of Alzheimer disease. No more brain disease or other processes are better explanation for the dementia. The laboratory test for the Alzheimer disease is to rule out the vitamin 12 or folate deficiency and hypothyroidism with thyroid function test. Other diagnostic tests are CT and MRI. So, this, according to the National Institute of Neurological and Communicative Disorder and Stroke and Alzheimer Disease and Related Disorder Association (ADRDA), it developed criteria and diagnostic workup for probable Alzheimer disease. The first, I have to take the history of the progressive cognitive decline or incidence onset in depth. We have to uh, mark the parameters whether the patient is falling in this or no. These are the mini mental status examination, commonly used to scale the measure of the orientation, how much the patient is able to recall, is the memory is short term loss or a long term loss, or what is the concentration of the patient, what is the age group, other explainable whatever the cause is. So these are the basically uh, the Alzheimer disease diagnostic parameters to rule out the Alzheimer disease. So this is a treatment algorithm for the Alzheimer disease. First of all, you have to treat the cognitive treatment. The patient is diagnosed with the Alzheimer disease according to the NIMCDS or ADRDA criteria. Assess all the comorbid medical disorders and the drug therapies that may be affect the cognition, and you have to rule out the comorbid depressions and evaluate for the pharmacotherapy based on illness stage, whether it is moderate or severe Alzheimer's or mild Alzheimer's. If it is a moderate or severe, then we will give a cholinesterase inhibitor, mementamine, or combination of cholinesterase inhibitors and mementamine plus with the vitamin E. If it is stable with MMSE, which is a mini mental status examination, then continue the regimen above. Otherwise, you have to repeat the whole process. And if it is a mild Alzheimer, we have to give a cholinesterase inhibitor or a mementortin with a vitamin E. We have will deteriorate that what is the according to the MMSE scale, which should be greater than or equal to 4 point. Dedine over the 1 year and alternate from above, plus we have to give the vitamin E. What are the common psychiatric or behavioral symptoms? So, psychiatric assessment address medical comorbidities, address the concomitant drug therapy for the potential side effects, first of all, and then the environmental and psychological interventions. We will divide it into three. If the patient is in depression state, whether it is psychosis or agitation, according to that, the in present condition of the patient, we will plan the therapy. If the patient is in depression, we will give a citalopram or sertraline, or other alternative opinion from above. We can give a fluoxetine, paroxetine, venlafaxine, or miltaxapine. If the patient is on psychosis state, we will give antipsychotics like olanzapam or risperidone. Alternate options from the above, we can give a quetiapine or haloperidol. If the patient is in agitation state, we will give olanzapam or risperidone. If the alternative from above, we give a citalopram or carbamazepine, or we can give a combination of oxypam, buspirone, trazodone, or salicylate. So, according to the guidelines, the treatment approach of the Alzheimer disease is the non-pharmacological therapy as well as the pharmacological therapy. In pharmacological therapy, we will give the medicines, pharmacotherapy of the cognitive symptoms, and give a cholinesterase inhibitors and other agents as as stated in our slide. according to the psychosis condition, whether the patient is depressed or uh, in other different stages. The most common cholinesterase inhibitor is donepezil. Donepezil is a piperidine cholinesterase inhibitor with a specificity for inhibition of acetylcholinesterase. It is approved for the treatment of cognitive impairment in mild to moderate severe Alzheimer's disease and also be effective to moderate to severe Alzheimer's. The patient improved the cognition for the first 6 to 9 months, followed by a gradual decline, and the dose of 5 mg and 10 mg can be given daily. Donepezil is well tolerated by most patients, so the common side effects are nausea, vomiting, diarrhea, headache, and insomnia. Can be tolerable and can be given a medicine for that. Next is Orivastigmine. It is a centrally active activity at show the central activity at acetylcholinesterase and butyrylcholinesterase, but show the low activity at the sites in the peripheral. So show a fewer peripheral side effects, and the efficacy of the doses is 6 to 12 mg per day. Next drug is galantamine. It is a cholinesterase inhibitor and also has activity as a nicotinic receptor agonist, and it causes a modest cognitive impairment which lasts for 9 months. The dose of the galantamine is 16 mg per day or 24-32 mg per day. The maximum dose recommended by the manufacturer at this time is 24 mg per day, and it causes some of the side effects which can be minimized, which can be neglected, not dangerous. Other agents are mementamine and NMDA antagonists. It blocks the NMD receptors, excitotoxic reactions, which ultimately lead to the cell death. It may be preventable. It indicated for the use in Alzheimer patients with moderate to severe illness, and the dose should be initiated with the 5 mg once a day, and it can be increased weekly by 5 mg a day to the effective dose of 10 mg twice daily. The patient should be given with vitamin E and salicylate. Vitamin E is often recommended as adjunctive treatment of Alzheimer's disease, and it should be titrated to a maintenance dose of 10,000 international units twice a day. The patient should be given with the anti-inflammatory agents. Treatment for less than 2 years has been associated with the lower risk of Alzheimer's disease. So, endomethacin, prednisone, diclofenac, misoprostol can be given. Lipid lowering agents also given to the Alzheimer patients to potential protective effects in the Alzheimer patients of lowering the lipid lowering agents, particularly with 3-hydroxy 3-methylbutyryl coenzyme A, HMG-CoA reductase inhibitors like atorvastatin is currently being studied in the clinical trials. Uh, Ginkgo biloba is also used to improve the memory. It also other than that, environmental intentions, antipsychotics is must. Antipsychotic, antidepressants, and thank you for all this Alzheimer's disease.